All right, now let's go into the individual details. All right, so let's start with the ratios. 1:300. So how did they come with the ratio 1:300? So we just need to know how the NAP7 is structured. So NAP7 basically is National Audit Project 7, which focuses on perioperative cardiac arrest, and it collected all the perioperative cardiac arrest for a period of 1 year. Okay, and these are the inclusion criteria. So from the start of the anesthesia up to 24 hours after the handover, there's the inclusion period, and any patients who had 5 or more chest compressions or defibrillation will be included. Anyone has procedure under anesthesia, so it has to have both criteria. The patient should have procedure under the care of anesthetist, plus the patient should have a cardiac arrest with 5 more chest compressions or defibrillation. It has 3 parts. There's a baseline survey at the start where they looked at the preparation of the local department structures, and then there is an activity survey, which is a 4-day activity survey of all the sites, and this is used to establish the denominator data. And then the case reporting is 1 year period where they report any cardiac arrest which fits the criteria to the NAP7 group. Okay, so this is the activity survey. So activity survey is used for the denominator data, and this is not specific to NAP7. So if you look at the other NAP projects, they all have activity survey duration. Activity survey duration is to capture all the anesthetic activity happening in a short period of time and extrapolating the data for the whole year to estimate the total number of anesthetic administered in a year. Say, for example, NAP4, it was 2 days, NAP5 is 5 days, NAP6, it is 2 weeks, and NAP7, that we're seeing now, is for 4 days. And this is the total estimated number of anesthetics per year, pretty much constant, 2.9 million, 3 million, 2.71 million in NAP7. Okay, finally collected around 24,000 cases in the activity survey in the 4-day period. And then what they did is then they scaled up for the year. So they used a Pandit method for annual caseload, and they estimated that the annual caseload is 2.71 million based on this activity survey. Okay, that's what the activity survey is used for. So 1 year of reporting. So in 1 year period, from 16 June 2021 to 15 June 2022, all the cardiac arrests occurring in the perioperative setting have to be reported. What they found, they had 881 cases of cardiac arrest reported in that 1 year period. And the total number of patients anesthetized in the 1 year period is 2.71 million. This is an extrapolation from the 4-day activity survey data. So the incidence then became 1 in 3,000. It's important to note the older and frail patients are higher incidence, 1 in 1,200, 1 in 1,200, and ASV 1 and 2 patients are very low incidence, 1 in 8,000, which is very reassuring. Okay, so the overall incidence is 1 in 3,000. It's higher in older and frail patients, lower in ASV1 and 2 patients, as you'd expect. Okay, so that's the instance. Next, we're coming into the patient characteristics. So what they did again is they used the activity survey, extrapolated the data, and superimposed the mortality data according to the age group. And when they did that, what they found out, this particular group of patients were overrepresented in the cardiac arrest category. So the purple lines here are the total number of cases, the proportion of total number of cases in a year in that particular segment. Say, so from the age 26 to 35, this is the number of percentage of cases from the extrapolated from the activity survey. And the blue bar represents the number of cardiac arrests, the percentage of cardiac arrests within that age group. Okay, right? So when you look at this, as you can see, so there's a bimodal distribution. So in neonates and elderly population, the incidence of cardiac arrest is much higher than the other age group, which again is kind of expected. So it's significant to see once they cross 65, the incidence of cardiac arrest increases massively. Same thing with neonates and infants. Okay. Again, when you look at the frailty score, patients who are not frail had lesser proportion of cardiac arrest patients reported in their group compared to more frail patients. The more frail the patient is, the higher is the incidence of cardiac arrest. Again, no surprises there. Males are slightly higher, ASA 3, 4, 5, higher incidence of perioperative cardiac arrest. Again, these are all pretty obvious. And when you look at the ethnicity, there isn't much difference. And again, the BMI, The higher you go, higher incidence of cardiac arrest. So these are the stuff that came out, that we saw earlier in the GAMT. The age, the frailty, presence of comorbidities, obesity. These are the patient characteristics that have high chance of having a perioperative cardiac arrest. And then we're going to go. You look into the surgical specialty. So orthopedic trauma leads by a mile. Then lower GI abdominal, mostly related to sepsis, perforated bowel, etc. Cardiac surgery, vascular surgery, cardiology, general surgery. These constitute one of the top 6 or 7 surgical specialties with high prevalence of cardiac arrest. Okay. When you look at the relative risk, okay, so the total number of general surgery obviously done is very high compared to the cardiac surgery in a year. Right? But the proportion of cardiac arrest in cardiac surgery is much higher than general surgeries. That's what this graph is predicting. This is the total percentage of cases. This is the number of cardiac arrests. As you can see, obstetrics, orthopedic trauma, and general surgery, they have high volumes of cases. So thereby, they have higher percentage of cardiac arrest possible because with the sheer increasing number of cases. Whereas when you look at cardiac surgery, cardiology, and vascular, they only consider a small proportion of cases compared to trauma, general surgery, and obstetrics, but they constitute a very high percentage of cardiac arrest. So if you're working in any of these specialties, cardiac surgery, vascular, and cardiology, you probably know that it's much higher risk of cardiac arrest in this specialty than other specialty. So what is the perioperative phase of cardiac arrest? When does it actually happen? The majority of the cardiac arrest happen during surgery. The next highest incidence, I was a bit surprised to see this, is postoperative after discharge from the recovery room. That's the second highest. So I was surprised to see this. So, and then comes after induction, but before the surgery is started, and then the equal percentage at induction. So at pre-induction, transfer to theatre. So if you look at that, pre-induction, at induction, transfer to theatre, after induction. So all these happen before the surgery is even started. So when you look at the association, so GA and GA plus neuraxial have higher incidence of perioperative cardiac arrest than neuraxial alone, or regional anesthesia, or regional sedation. Again, evening and night times are overrepresented. Expedited, urgent, immediate surgeries, they all have higher incidence of perioperative cardiac arrest than elective surgeries. No surprises here again. So again, the grid of surgery, major and complex surgeries are way overrepresented in the perioperative cardiac arrest group and the weekend surgery. So that's what's all represented in the GAMT here. Okay, so you have the urgent surgeries, out of hour surgeries, duration, complexity. So all of these things, factors, increase the risk of perioperative cardiac arrest. Okay. Right. Next, we're going to go into the causes. So the cause is interesting because they did a survey, baseline survey at the start, and they asked the anesthetist what they thought was the most common cause of perioperative cardiac arrest. And this is what the anesthetist thought before the NAP7 project. And most of the anesthetists thought hypovolemia is the number one cause, followed by hypoxemia, followed by cardiac, anaphylaxis, and hemorrhage. So hemorrhage was way down their list. This is the actual causes of cardiac arrest reported in NAP7. So major hemorrhage is the highest, bradyarrhythmia is second, cardiac ischemia third, septic shock is fourth. The anaphylaxis is nowhere to be seen yet, right? It's kind of way down the list. Isolated severe hypertension, severe hypoxemia, and then comes the anaphylaxis. So anesthetists tend to overestimate anaphylaxis as a cause of cardiac arrest. In fact, it wasn't in the top 5. It's the 7th most common cause. Major hemorrhage obviously is one of the most important causes of cardiac arrest. So the next most important things that we all need to look at is the areas of potential improvement. What can I do as an anesthetist to reduce this from happening? So there are 5 main things which are highlighted in the NAP7s. First is the monitoring, the risk assessment, drug dose, drug selection, and operating room. Okay. So what is monitoring? This is the whole chapter on this monitoring and perioperative cardiac arrest. During our general anesthesia, no problems, right? The issue with the monitoring is always during transfers. So 1/3 of the patients are not conditionally monitored between anesthetic room and theatre. Almost half the patients are not conditionally monitored from theatre to the recovery area. So these are the 2 main points that's highlighted in NAP7. The other point that they noted is capnography is only used in 50% of the cases where minimal sedation is in the conscious level, and it's only used in 27% of the transfers. So they kind of strongly recommend increase in capnography use during the transfers as well. That's one of the deficits that they pointed out during the SNAP-7 study. Compliance is great. There's a gap in monitoring the anesthetic room and theatre and from theatre to the recovery that could be prevented. One third of the patient are not monitored from anesthetic room to theatre, and 50% not monitored between theatre and recovery. So there are potential um, areas of improvement. Use of capnography during sedation or transfer with an airway in place does not happen. There should be resources available in every setting to make this possible. So there's a big push for having capnography monitored throughout the transfer as well. They do make a statement on processed EEG that then should be considered for patients having volatile anesthetic who are high risk. I'm not sure how much evidence that is based on, but it's in the recommendation. Okay. Okay. Next is risk assessment. Okay. This is again very interesting. Most of the patients didn't have a surgery specific score. Most of the patients didn't have a qualitative score. Quantitative score, like for example ASA, even if it was present, was not accurate. A lot of the patients were underscored based on the ASA. For example, so if you look at the cardiovascular disease, anyone with the cardiovascular disease, TSCVA, should be a minimum of ASA 3. And there are 152 patients were scored as ASA 2. Right? MI or acute coronary syndrome within 3 months, actually pretty high risk. They should be ASA 4 or greater, but 54% of them are underscored. MI or acute coronary syndrome older than 3 months should be at least ASA 3. Again, underscored here. Severe aortic stenosis should be ASA 4. Again, 66% of them are underscored. Congestive cardiac failure, NHA grade 3 or 4, should be ASA 4. Okay. Permanent pacemaker, this somebody who has a permanent pacemaker by default goes to ASA 3. Same thing, implantable cardiovascular defibrillator, right? And chronic kidney disease, at least ASA 3. So the last three are fine, but the first 4 or 5, they've been grossly underscored. So it's important that you have a proper ASA grading documented in the chart. The other thing that the authors noted was the BMI. So when the BMI is more than 30, they fall under ASA 2. Okay? The BMI is more than 40, they actually go to ASA 3 by default. So 38% of that is underscored. So anybody's BMI is more than 40 by default goes to ASA 3. This is some of the examples, but the point they're trying to highlight is that you need to have proper ASA grading documentation. The other important thing that they comment out is that the use of qualitative surgical assessment tools. So SORT is an example they used. Surgical outcome risk tool. This you can do it online. Scoring system, you put in the details and it produces a number. So the SORT risk, if it's less than 1, risk of mortality. The risk of cardiac arrest is 1 in 7,000, right? Very low. When the SORT risk is 5 to 10%, the risk of cardiac arrest is 1 in 1,300. It goes up dramatically, right? And then if the SORT risk is more than 10%, the risk of cardiac arrest is 1 in 170. There's a massive jump. The ASA grading and the SORT score are very useful too. As we already saw, the ASA 3, 4, 5 obviously has a high risk of cardiac arrest. SORT score is an online tool, so it's an online tool, so surgical outcome risk tool, so it's NC point. So this is how it looks like. So you just need to say, let's say you're doing rib fracture, so I'm going to say, bone and joints and kind of tissue and subgroup femur. So fracture pelvis, sternum, femur. So primary reduction of fraction of femurs and implant fixation, and automatically it goes to severity. So this is the first year to kind of identify the severity of the surgery. So let's say ASA 3 and urgent. Thoracic gastrointestinal vascular surgery, no. Cancer, no. Age 65, 61. So there's a clinician risk assessment. The orthopedic team or the orthogeriatric team should have risk assessment made. You can just don't know if there's no of that in this box. And then you see the mortality risk is 4%, 4.15%. If you change the age to 79, it's 8.9%. If there's cancer, it goes to 15%. This is a very useful tool. Just takes a few minutes, so it can be very easily used. All right, perfect. Other quantitative tool they scope is clinical frailty scale. And what they noted is any frailty scale of 5 or above, the risk of cardiac arrest, periodic cardiac arrest increases exponentially. So this is a clinical frailty score recommended by Rockwood et al., published first in 2005. It's a very easy scoring to use. As you can see, it starts from very fit to well to managing well. So you can see the amount of support they need to walk increases. They use an umbrella, and if they use a walking stick, they're vulnerable, point at which it becomes a little bit more trickier. And they're mildly frail, and then if they need another person to help them, it becomes moderately frail, wheelchair bound, severely frail, very severely frail, and terminally ill. Right? So it's very the image itself is very easy to understand, easy to remember. So frail skull is again similar to AZ skull, very easy to apply on the bedside. So when you talk about risk assessment, there are two types of risk assessment one can do. Is qualitative risk assessment, quantitative risk assessment. The qualitative is short, as we saw earlier. You input numbers, you get a percentage of figure, and the quantitative is like ASA score and clinical failure score. So both has to be combined to get the maximum benefit. When a patient comes to the OR, quick ASA plus clinical failure score, along with either SORT, NELA, or Nottingham hip fracture database score, if there's patient has hip fracture, will give a very good estimate going into the surgery. These qualitative scores, SORT, NELA, and Nottingham hip fracture, for example, they're easily available online. All you have to do is just go online, type for the score, and the parameters will come up. You just enter the details and you'll get the output. And ASA and clinical failure score, as we saw earlier, are pretty straightforward as well. So it's a very useful thing to do, especially when you're dealing with a high risk patient. So that's about risk management. The next point is about drug dose and drug selection. This is very interesting. And let's see what they have to say. So drug choice and dosing just have contributed a substantial portion of perioperative cardiac arrest. This is very important. It's something that we can actually do to prevent it. Issues on choice or dosing of anesthetic drugs are more common in older and frail patients, higher grade ASA and acute illness. So all these patient groups which are high risk of cardiac arrest had the issue of poor choosing of drug and the dose of drugs. Okay. In 12 cases, the panel thought ketamine should have been better instead of using propofol. And use of vasopressors around induction might have prevented. These are things that you can do. Failure to tailor TIVA or remifentanil to individual patients just have contributed a number of cardiac arrest on induction. This is again very, very important. The TIVA has become more popular nowadays, so it's very important for us to remember. TIVA is not a solution for everything. When you actually have an older and frailer patient, you just need to make sure, if you're using TIVA, to make sure you titrate the doses appropriately. Right? The administration of epidural test dose contribute cardiac arrest in drug replacement, and drug errors continue to happen. So they're giving some few good examples. So let's look at the examples. A healthy middle-aged patient is a one with a slow heart rate at rest, present for day case procedures, increasingly bradycardic after answering injection of propofol, remifentanil infusion in Midasna. Glycoprotein ineffective patient required cardiac resuscitation, titrated patient, did fine afterwards. But again, TIVA, propofol, remifentanil. Previous healthy middle-aged patient with polytrauma requiring long bone fixation, induction with propofol and remifentanil TIVA was rapidly followed by circulatory collapse and PEA. So probably the hypovolemia was not properly resuscitated. On top of that, propofol remifentanil didn't help either. Older patient AZ2 and pre-existing beta blocker treatment undergoing expert orthopedic procedure. Induction with propofol and remifentanil TIVA. Certain profound hypertension, cardiac arrest. And again, the concentration of propofol chosen was very high, something like say high initial bolus. Right? So it's very important to keep an eye on that. Middle-aged patient AZ4 requiring emergency laparotomy for perforated viscous. Septic shock requires supplemental oxygen before surgery. Risk of mortality greater than 10%. Induction with propofol, patient become hypertensive at a cardiac arrest. Dose administration metronidazole, despite dose adjustment in metronidazole. The case when performed minor cause circulatory deposit, ketamine might have been preferred. Again, I'm not so sure about that. Whether ketamine is going to make a difference, don't know. Not sure. And again, middle-aged man AZ3, severe obesity, difficult intravenous access, underwent electric joint replacement, spinal anesthesia were technically challenging. No target control infusion available, so the patient was given propofol sedation as an initial manual bolus, followed by mg per kg per hour. During the case, oxygen desiccation, respiratory arrest with bradycardia, progressing to asystolic arrest. Again, um, any high-risk patient, obesity, a red flag. Frail, old age patients, all red flags. Has to be careful with the drug dosing and drug selection. Older patient, ASA4, significant cardiac history, emergency laparotomy. Again, all the red flags are there already. Severe septic shock, tachycardia, and hypertension before anesthesia risk, because when you get more than 10%. Initial epidural bolus, now that's definitely shouldn't be given. At the time of induction of anesthesia, cardiac arrest occurs soon after. What else do you expect? That's it. There you go. So I mean, these case studies, most of it will be obvious, but it's kind of a nice reminder for us to make sure that we are conscious when you're selecting a dose and titrating the dose for any patient, especially the high risk group patients. That's why it's important to have the high risk patients category in your mind: obesity, age, frailty, comorbidity, urgency, sort of duration, complexity. Any of these patients, just to be careful with drug dosage and drug rate of drug use. So they suggest for individual practice. Um, so individual practice should recognize the following high-risk cardiovascular cases: hypolimic cardiovascular instable patients, frail older patients, patients with vascular surgery, bradycardia, surgery, vagal syndrome. So induction technique, medical modification using ketamine instead of propofol, or by co-administering vasopressor medication. High dose or rapidly administered propofol in combination with remifentanil should be avoided. Very important. Take-home message. Anesthesists make a proper judgment. Initial TIVA target concentration frail old patients. TIVA intervention into knowledge of models, usually specific training to do so effectively, is very important to have proper training for TIVA if you're using TIVA. The risk of bradycardia when using remifentanil should be carefully used. Report drug errors, of course, epidural test or severe dose of testosterone, and be careful. Okay, so these are the important take-home points with regards to drug dose and drug selection. Right, and finally, coming on to the operating room. So the suggestion was made that high-risk patients should be anesthetized in the operating room when the patient is anesthetized in anesthetic room. So these are the causes. It's already massive hemorrhage is the cause of death overall, but when the patient is in the anesthetic room, severe hypertension, bradyarrhythmia, severe hypoxemia, anaphylaxis, and drug errors. These are all the causes of cardiac arrest and septic shock. Cardiac arrest when the patient is anesthetized in the anesthetic room. So majority potentially are preventable. So a young previously healthy patient was anesthetized in anesthetic room for fixation of long bone fracture. Patient was tachycardic on arrival to anesthetic room, had a PA cardiac arrest after induction to anesthesia. Patient was resuscitated short duration CPR and blood administration. This patient was previous massive hemorrhage, untreated hypovolemia. Again, anesthetic room may not be an ideal place to anesthetize this patient. An older patient present with septic shock and bowel ischemia, an emergency laparotomy. Again, all red flags, straight away go to the anesthetic room. Straight away go to the theatre, not the anesthetic room. Patient high estimated risk of death. Shortly after induction of general anesthesia, the patient had a cardiac arrest, of course. Patient initially successfully died on the inlet and anesthesia unit. Should be anesthetized in theatre. Now, anesthetizing this patient in theatre, would it have changed the outcome? Probably not. But at least you'll be in a better position to manage the cardiac arrest if that has to happen. The young, previously healthy patient who had airway bleeding was anesthetized in the anesthetic room. Again, a red flag. Don't do this. Relook ear nose procedure. The patient was tachycardic before induction of anesthesia and shortly after induction of cardiac arrest because of underlying hypovolemia. Patient was resuscitated with a good recovery. Again, you know, better drug dose, titration, location of the patient in the anesthetic room, all these things would have kind of smoothened the effect a little bit. Okay, there you go. So that's for the operating room. So that covers most of it, right? So hopefully you guys have a very good idea of NAP 7 now. I thought I could just get this done in a day. It took almost 3 weeks for me to put all this content together. And it's very useful. I found it very useful. It's a very useful exercise. And I think people who are going for exams will find this GAMT very useful. And I think even for everyday anesthetic practitioner might find this GAMT very useful as well. It kind of constantly reminds some of the high risk patients, kind of constantly reminds you about the most common causes of cardiac arrest and what are the potential areas. So what should you be thinking about? Should be thinking about monitoring, should be thinking about risk assessment, should be thinking about drug dose and drug selection, and should think about should I do it here in the operating room. So when you did any of these high risk patients, think about all this. Okay, all right. Hope you liked it. So I'm hoping to come out with more of these camps for anesthesia related topics in the future. So if you have any topic in your mind that you think that you need a GAMT for, please mention it in the comment. Your comments and your likes are very valuable. So please engage with the video, and please don't forget to subscribe to the GAMTpedia channel. And please don't forget to visit www.gamppedia.com. As I told you before, we are getting an app ready for the GAMT. So all you have to do is enter the keywords from a topic, and it produces a GAMT. I think it'll change the learning landscape big time. And I can't wait. I'm really excited. I can't wait to release that, guys. It'll probably take a good few months, but hopefully will be there. See you in the next video. Learn it, GAMT it.